We're testing. Okay.
Morning. Bob. Hey, Bob, can you hear us okay?
Good morning, friends. Can people see me, hear me? Or people hear me?
We hear you.
I do not hear you. Yeah, my camera's off.
Oh boy, James, I can't hear you.
Hello, hello.
Why does this seem to happen so frequently when I'm using Chrome? Yeah, I'm looking at the audio settings as I'm using my computer audio.
Yeah, I tried that.
Hello again. Hello, hello, Bob.
Yeah, I know, Matt. Matt,
Say something now.
Hello, hello.
Oh, I can hear you and it sounds beautiful.
Great. All right, you're all set.
Whoop, whoop. Good morning, people. We'll let people trickle in here. That morning trickle. Doing well to us and our BPH patients. Started in about 2 minutes here. We'll give about 2 minutes to call in. At 21 participants so far. I told 20, never do anything without 23 people.
Given my seniority, Bob, can I count as two?
Yes, you do. Well, in that case, the time is 7:35. So how about we get started? If anyone's having trouble hearing or seeing, just go ahead and hit the raise your hand thing. I don't know if I can actually see that while I'm sharing the screen. Can someone? Do we even have raise hand on WebEx? We might not actually have that. So.
Negative.
Negative. Type something in the chat box. I'll see it there. I've got that open, and we can go from there. A couple other announcements. Tressa wants you to know that this is an EEDS thing, so sign in on there should you seek credit for this. I think that's about it. So, welcome to this talk about primary care after critical illness. My name is Bob Fidel, and I have no disclosure. So the objectives of our talk, our goals, are to talk a little bit about something called post-intensive care syndrome. We'll talk about the risk factors that are involved in post-intensive care syndrome. its prognosis, and how you should manage it. This includes the categories of physical problems, cognitive problems, other psychiatric symptoms that develop in survivors, and other common problems as well. We will touch briefly on how to prevent post-intensive care syndrome, even though that's mainly going to be the intensivist's job, but since us residents spend a fair bit of time in the ICU, I think it's worthwhile to briefly mention. From our experience in the ICU, we know that critical care illness impacts families and caregivers. So we will talk about how PICS affects families and caregivers as well. And finally, I will review all of this and provide concrete ways that as a primary care doctor, you can care for ICU survivors. You should look forward to the end. I'm going to distill everything down into one high-yield slide that you can take with you for posterity. Time for a brief survey. So whether it's in the chat feature or just over the phone, either like raise your hand, type a comment, or let me know if a patient of yours has survived the ICU. Someone from the FM Peds room. Allie Wolf. Someone's trying to say something. Jake Starziak. Dan Samuelson says no. And several other people, lots of people saying yes. Even a few first-year residents here are already saying yes that their patients have survived the ICU. So me too. For those of you who didn't raise your hand, just wait. With advances in medicine, the population of like critical illness survivors is increasing, and you're going to come across a survivor one day. Every year, there's about 5 million ICU survivors in the United States, which actually kind of blew my mind that it was that many people. I think some of those in the data they collected are like repeat people, like people who visit the ICU multiple times a year, but still 5 million people survive an ICU in the United States every year. I was personally inspired to give this talk after a 68-year-old patient of mine survived the ICU. He contracted COVID in late March and required 5 days in the ICU, intubated, briefly on pressors, followed by about 12 more days of hospitalization. He was in rehab for about a month, and then he showed up to my clinic after he was discharged from the SNF with lots of new problems, concerns, and questions. He and his wife told me about weakness and fatigue, memory problems, trouble swallowing, these anxiety attacks he was having. The list was really long. As I assessed these different issues and thought about treatment, I came across this little something called post-intensive care syndrome, which really helped me to establish a great framework to manage his symptoms. So, what is this post-intensive care syndrome? I think someone is not muted. I heard noise. Just FYI for those of you who are on the call. So there's no official definition for post-intensive care syndrome yet, but there are multiple guideline statements from different critical care associations, American Thoracic Association. They've kind of started to agree upon a general understanding of what it is. In general, it describes new or worsening impairment in cognition, mental health, and physical function. And each of those are interrelated, and each of those also have subcategories with their own unique risk factors, prognosis, and treatment. So we're going to dive into those a bit more. This post-intensive care syndrome applies to adults specifically outside of the hospital after critical illness. There are some, in some ways, people have been applying the PICS definition to kids as well, but it's just not where they got the original data from. So certainly you may see these things in kids, but this particular information today was gathered from adult patients. This excludes stroke patients, since patients with stroke have very organic reasons for long-term or transient even troubles with cognition, mental health, and physical function. So this post-intensive care syndrome is wildly common. 64% of survivors at 3 months are going to have the syndrome, and then at 12 months, not that many fewer, still quite a few, still over half are going to have some symptoms. And this is important to know about because it's associated with an increased risk of death, particularly decreased quality of life, delayed return to work, if ever returning to work, and also decreased family income. About a third of families repeat that their who then cannot work has a significant financial stress, adds a significant financial stress to the family. Let's dive into the categories. So the first of those categories being the cognitive impairment. Yes. Sure. Does someone have a question? Okay, there we go. Now we're muted. Okay, great. So cognitive impairment, after critical illness, common cognitive deficits you're going to see involve the executive functions, memory, attention, processing speed, and that visual spatial ability. Executive function and memory problems are the most common. And this actually presents like a traumatic TBI, like a TBI, like a moderate or a mild one, and sometimes like mild dementia as well, but it can be more severe. The patient or caregiver might start to tell you that they're having trouble with short-term memory issues, amnesia, there's difficulty concentrating even on small tasks at home. And then often you'll hear this concern. It's like, I ask them a question and it takes them like 4 or 5 seconds to get back to me with an answer. For some people like me, my fiance would say that's normal, but for other people, that's not. So when you hear those sorts of things, you should start to worry that there's some sort of cognitive impairment post-critical illness going on. You may see these sort of issues lead to difficulty with medication adherence as well, for not remembering things, or having trouble processing what you're telling them in clinic, and also difficulty maintaining appointments. So a lot of these patients require additional social supports in that regard. It is pretty common, but also variably common. The incidence is about 25 to 80% depending on the study that you look at. And risk factors include things like how long you were sedated, if you had delirium in the ICU, how bad your hypoxia was, and if your glucose was or wasn't well controlled in the hospital. The prognosis from the literature I reviewed is generally modest. Patients will show marked recovery in the first year. Some of them will, but others have like these persisting long-term deficits from cognitive impairment. So the good news is that there are things we can do to help. So it's important to evaluate these patients in the outpatient setting. Moving into that. The critical care groups recommend screening all intensive care survivors for cognitive impairment. There's no screening tool that's actually been validated for post-intensive care syndrome. So for now, they're saying just use the one that you're more familiar with, whether that's MMSE, Minicog, or the MoCA. The MoCA, from the reading I was doing in this case, is slightly preferred because it incorporates that assessment of executive function. So it's a little bit more sensitive for mild impairment. The particular aspects of that MoCA that assess that executive function are that trail making test when you're connecting like A1, B2, the phonetic fluency, so as many words that you can think of that start with an F, and verbal extraction. And that's like finding commonalities between pairs of words. I see someone asking me a question about using the slums. Slums was not on the list of like the recommended ones to consider using, so I didn't include it on there. But again, since there's no data supporting validating any of these, I think use what you think is a little bit more comfortable to you. So regarding treatment, I again want to emphasize that there is an opportunity for improvement in cognitive impairment with good treatment, especially with the executive function. So it's important to try treating it. Physical rehab seems to be, by far, the most effective element of treatment. So PT should start as early as possible, even in the ICU. It's actually safe to do PT in many cases in the ICU. Once strength improves, then you should highly encourage a regular exercise routine to help improve cognitive issues long term. So it's interesting that the physical aspect of things also helps cognitive. So that supports the idea that all these domains of PICS are very much so interrelated. The rest of treatment, and even this aspect really, but the rest of treatment is very much in line with how you would probably treat anyone with cognitive decline. We might get OT involved or find other ways to assist patients and develop compensation strategies using things like medication boxes, organizational aids, external memory cues. That's like alarms, reminders, keeping calendars. Memory training can help. Home health might be particularly helpful, or family members who can help at home. And there was relatively weak evidence to use pharmacologics, but they can, from what I was reading, they can generally be safely tried once you've sort of maximized everything else. Overall, if you treat your survivors who have cognitive impairment like you would treat any patient with a mild or moderate cognitive disorder, you're totally on the right track already. There's really not too much that's different or unique about it. Moving forward, we have mental health, which is our second of the three domains within the post-intensive care syndrome. This commonly involves depression in about 1 of 3 survivors, and then anxiety in about 1 in 5, and then PTSD in 1 in 5 to 1 to 10 patients. And we're going to talk a little bit more about each one of these in a moment. Some bad news is that the psychiatric symptoms tend to persist for years, even after survival, but it does kind of depend on each subcategory as well. This is even worse for ARDS survivors. Seems to be as like a subpopulation of ICU survivors. ARDS survivors seem to have worse outcomes in all 3 domains, but particularly mental health when it comes to anxiety and PTSD. So those also with pre-existing psych disease may have worsening mental health as well, or are more likely to have worse mental health issues after surviving. Like all mental health problems, it can have a great impact on quality of life for both the survivors and the caregivers. So it's important to work it up. The mental health issues present like classical depression, anxiety, and PTSD. So for depression, it's the anhedonia, poor appetite, sense of hopelessness, and insomnia. You'll see those just like you would in any typical depression patient. You should have a higher suspicion for any patient who you look in the record and see that they were sedated for a long amount of time. If they have physical impairments as well, if their body isn't working as well, they're more likely to get depressed. And those also use day was very traumatic to them. And I know that we've seen this in some of our COVID patients this year too. Fortunately, there usually is improvement in like PICS related depression in the first year. So the depression aspect has a bit of a better prognosis, especially as they physically recover and just get better with time. For anxiety, it's the typical symptoms of worry, irritability, restlessness, fatigue. Your patient would be at higher risk of this if they required extended mechanical ventilation, if they're young and female, or if they're unemployed. The prognosis for this is more likely to persist after a year than depression. For PTSD, it's the flashbacks, hyperarousal, severe anxiety, and avoidance of any of the experiences that, or any sort of experience that may evoke symptoms. That could be going to a doctor's office. Risk factors for this include the amount of sedation used, if they got agitated in the ICU, if you had to use restraints, and also these unfavorable ICU memories again. One thing though, the prognosis also for PTSD is like worse. It tends not to improve the best, so it's again good to know about and to treat. One thing that kind of makes the PICS-related mental health issues, all this depression, anxiety, and PTSD, slightly different than your standard mental health disorders is that patients' somatic symptoms, like survivors, will have a lot of somatic symptoms after surviving. And those symptoms are more frequently going to induce some of their psychiatric symptoms. So that again is kind of an example of how these domains can be interrelated. Absolutely, all survivors should be evaluated for depression, anxiety, and PTSD in the outpatient setting as soon as possible. So when that I would argue that first time that they're coming into you after surviving into the clinic, you should be assessing this. Just use whatever tool you prefer, knowing once again that no tool has been specifically validated for post-intensive care syndrome. So I would probably do the PHQ versus like Beck depression. I would probably do GAD-7 instead of the Beck anxiety inventory. And I'd probably do like DSM-5 for PTSD. But you can use whatever diagnostic tool you are more familiar with. If you identify a disorder, generally just treat it like you typically would. Use mindfulness techniques, get people with phone apps, prescribe SSRIs, try prazosin, get them involved with therapy, try counseling. I do wonder if you should maybe be a little bit more cautious with using like cardioactive substances like beta blockers or clonidine for PTSD, or things like bupropion for patients who maybe had seizures in the ICU, but I couldn't find any evidence for this. I just wonder if that's something to be a bit more cautious about. We again see that physical rehab is super helpful for mental health. And I also found a couple of studies about forming like peer support groups or even having these multidisciplinary survivor clinics, that the effectiveness of both of those things are mixed. The physical impairments after critical illness cause the greatest need for additional support at home, which can really burden families. So these are generally sorted into the categories of pulmonary, neuromuscular, and physical function. We'll get more specific with each of these in a moment as well. Incidence is also variable, but still common. And the prognosis is that it's overall likely to improve, but then there are some aspects that are persistent. To kind of demonstrate that, at 3 months, I found some data that the disability rates for IADLs and ADLs is about like 26 to 32% of patients, about a quarter to a third of patients. And 5 years out, on average, it's achieved like 75% of their expected physical function. So they get better, but they never quite get back to their baseline with physical function on average. The pulmonary impairment often manifests as dyspnea on exertion and involves these changes in lung volumes, forced expiratory volumes, and diffusion capacity. Intuitively, the pulmonary function tends to be worse for people who have been intubated for longer. The good news is that this actually usually improves. Spirometry can dramatically improve even by 6 months, but the diffusion capacity tends to take a little bit longer to normalize. Neuromuscular issues and ICU acquired weakness can manifest as just generalized weakness, having decreased sensation in parts of their body, pain, or this massively decreased muscle mass. I think there's been some social media pictures of this one like bodybuilder who got COVID and just like shrunk. So that is very common in these cases in survivors. The ICU acquired weakness is the most. I think I have someone who's accidentally come off mute. Those neuromuscular issues manifest as all those things that we were just talking about, but the most common thing is the ICU acquired weakness. The risk factors include this poorly controlled blood sugars, getting SIRS, getting septic, multiple organs being involved in your illness, immobility, especially if prolonged. For prognosis, the muscles will usually improve first and to grow back and get stronger first, and then the neuropathy, like you'd expect, may take up to 5 years or more to get better. For physical function, this applies to being able to do things and get around. So the clinical manifestations would be like poor mobility, needing help with transitions, frequent falls, difficulty feeding, dressing, preparing foods, handling medications, all those sorts of things. When patients get steroids or acquire infections in the ICU, they're at a greater risk of physical function problems, and age and pre-existing IDL problems are also risk factors. I mentioned the prognosis is that it usually improves, ADLs improve, and IDLs later, which makes sense. So absolutely get your survivors evaluated and followed by professionals. So PT and OT should be involved as soon as possible. Speech and swallow should be considered for patients with prolonged intubation, malnutrition, or those who are presenting with like trouble swallowing or other symptoms related to eating or talking, like hoarse voice. You should consider a dietitian if there are swallowing deficits or if there's a significant diet change that's needed after their critical illness, like a new renal diet, a new cardiac diet, a new diabetic diet, or if there's consistency changes that the patient needs. It's recommended to get PFTs for those patients who had ARDS or those who had critical illness and a previous underlying lung disease like COPD or asthma. Of course, whenever a patient of ours with COPD or asthma has a significant illness, you should probably get repeat PFTs, but just have a slightly higher threshold in this case for people who maybe didn't have underlying diagnosis, underlying lung disease, like if they just had ARDS, they should probably be getting PFTs after shortly after getting out of the ICU. You can do a 6-minute walk test in clinic to assess for exercise tolerance. Now, formal EMG and nerve conduction isn't necessarily recommended. You can use those to confirm underlying diagnoses like the PICS-related weakness, neuropathies, or myopathies, but it's often not necessary because the management isn't going to change. You're going to get these people involved with physical therapy no matter what. You also don't necessarily need to do like a cardiac stress test. You would using a multidisciplinary team. You want to focus on exercise and aiding mobility, adjusting their environment to reduce fall risk, make things easier at home for people, and then managing their symptoms like pain safely. Moving out of the 3 major PICS domains, there are still other common problems survivors face that are worth noting, but maybe weren't completely a part of the PICS subcategories. So, for example, some patients experience complications intubation, like laryngotracheal stenosis, tracheomalacia, vocal cord paralysis, and swallowing trouble. The swallowing trouble occurs in like 50% of patients who are intubated, but fortunately, it usually resolves with intervention. But these are also reasons to maybe get speech, swallow, and maybe ear, nose, and throat involved as well. Some patients may have persistent swallowing trouble or significant GI system injury after the critical illness, like after a GI bleed, for example. In those patients, malnutrition is super common. The patient might need tube feeds, they might need TPN. So you should watch for that and get people involved with nutrition if they need to. Contractures are also common, so you would treat them like you typically would with like orthopedics, PT, physical rehab. Sexual function is closely tied to PTSD and also other underlying mental health conditions after surviving. So first, treat that underlying cause, like that anxiety issue or the mental health issue, and then try like non-pharmacologic things for both men and women. And then you should be a bit cautious with pharmacotherapy there. Sleep disturbance common, so identify and treat the underlying cause with those. Lots of times that's also related to mental health issues. In general, quality of life is significantly impaired. It's largely related to the physical dysfunction in mental health, and it improves modestly over time, but often the quality of life never returns back to their baseline. So that can be kind of important in setting expectations for patients and families. The hospitalization risk is also really high for survivors, but proven to be preventable with really good ambulatory follow-up. So there's my plug for family medicine right there, and internal medicine, sure. Mortality risk is high, but the risk decreases significantly 3 to 6 months after their ICU stay. So once you kind of survive 6 months, then you're not quite in the clear, but you're definitely more in the clear than you were before. I'm sure a lot of you are wondering, well, what about specifically for our COVID survivors? Because we might be having a lot of those in the next few years. So I tried to do some research on this, but there really is not great evidence yet. Just hasn't been enough. The thought from experts is that COVID survivorship is probably going to mimic what ARD survivorship looks like. Now, again, in post-intensive care syndrome data, they included people who survived ARDS, but as a subset, if you just ARDS patients and look at their outcomes, it's a little bit different than the whole general PICS population, and it's a bit worse. So cognitively, the issues are a little bit more persistent in ARDS survivors because of the hypoxemia issues. Psychiatric issues like anxiety and PTSD are more likely, since prolonged intubation is more likely. And then the physical issues are also not so great. So ARDS patients are more likely to physically decline right after their illness and have deficits that are more persistent. But they still usually get normalization of spirometry within 6 months, about 6 months. I did find a study that talked about symptoms that you might see after patients who almost died from COVID show up in your office. Fatigue is the most common thing that they'll still be complaining of. Dyspnea, joint pain, chest pain. Those 4 things are all under that physical aspect of PICS. And then, of course, the cough and anosmia may persist as well. So there's some symptoms to be aware of, but still no specific recommendations for COVID yet. Preventing complications after the critical illness, again, chiefly the job of intensivists and hospitalists, but again, since a lot of us are working in the ICU as residents, then I think it's worth noting. So the A, B, C, D, E, F mnemonic will impress your ICU attendings, maybe even Dr. Taylor if you're lucky. So the ABCs are your sedation vacations and breathing trials, the awakening and breathing coordination. D is following good delirium. Came up sooner than I wanted it to. Delirium is following delirium precautions. E is the early ambulation and PT. Besides this enough, it can be safe for patients who are still on mild sedatives or even pressors, which I didn't know that. That was a good learning point for me. F is not for friends who do stuff together, as SpongeBob would say, but for family who does the ICU together. Visitor restrictions are so detrimental to this, but there is emerging data that getting people connected with their families on video in the ICU or in the hospital is actually making a big difference. I would add a G for normal glycemia. So getting patients on insulin drip and titrating to goals safely is going to be important for preventing PICS. And then finally, there's some mixed data on ICU diaries that patients can use to hopefully foster factual memories of their experience in the ICU. But again, that data is mixed. So before chalking up all of your survivor symptoms to the post-intensive care syndrome, we should be sure to consider the differential. Pre-existing conditions like dementia, depression, and anxiety, or failure to thrive may confound post-intensive care syndrome. If you don't know what the patient's baseline was when they show up in your clinic, engage family members, ask about their pre-ICU baseline. organic things like CVA, having like strokes after critical illness. We know that it looks like people who get COVID might be slightly high risk of having embolic events. So they could be having strokes as well after the critical illness. So keep that in mind. Um, there could be thyroid disorders, anemia, obstructive sleep apnea, and cancer, which can be bad to miss, obviously. Other things would be keeping an eye out for rhabdo, Guillain-Barré, and the post-hospital syndrome. Post-hospital syndrome is kind of similar to PICS, but it only lasts days to weeks and is usually in older people. The guidelines highly recommend doing a workup, standard workup in any survivors. So that includes the CBC with differential, your BMP and liver function tests, ion studies, B12, TSH, and a chest X-ray. Optional stuff is kind of the CT head. If you think they might be having strokes, you might consider that CT head. You might get a sleep study if you're worried about OSA being involved. And it doesn't really change management, but you could consider that if you want to do. That's kind of the optional stuff, but you definitely want to do those other 7 things. I would totally fail to do my job as a family medicine resident if I did not mention how PICS affects the family. In fact, it's got its very own creative name, PICS-F. So this describes the post-intensive care syndrome for the family, describes the effects that critical illness has on family members, any family member. It includes symptoms that occur while their loved one is still in the ICU and then after the ICU as well. It also includes symptoms that families may experience following the death of their loved one. At least 16% of family members will experience depression. I found it really interesting that risk factors are indeed distance to the hospital, restricted visiting, and then younger patients and female patients. So like a patient's young daughter who lives in California during times of COVID is probably the worst case scenario for that daughter. I thought that was kind of interesting. For PTSD, at least 33% of family members will experience PTSD. The risk factors for this is if those family members feel dissatisfied with the communication that they had with the physicians and doctors and team in the ICU, if they felt their ICU physician was, quote, uncaring, and if there was like that mismatch in decision making, like the family was like, well, we think we should go ahead with this treatment, and the ICU doctor or the team was like, no, we would recommend this. That kind of mismatch can increase the risk of having post-traumatic stress disorder for family members. At least 50% of family members will experience anxiety. I found this interesting as well. Don't judge families on their stress level for patients who were like only in the ICU overnight, because severity of illness is not a risk factor for anxiety. You could almost hear someone say like, "Yeah, my patient was in the ICU, in the ICU overnight, got out," and then you might think in your head, "Oh, that's not bad." But for the family members, they're still in the ICU, and we know that the anxiety is not related to how severely ill their loved one was, so keep that in mind. Complicated grief is also common, and when the family does not have knowledge of their patient's wishes, they're at higher risk. We'll get more into preventing that in a moment. Sleep deprivation is also common, either because of the aforementioned issues keeping them from sleeping, or also because they're getting phone calls in the middle of the night regarding treatment decisions, or they're staying at the hospital and not sleeping well, or having to take care of more duties at home because their loved one isn't there. For prevention and treatment, good and frequent communication with families involving family actually does improve this. Allowing family visits is important. Once again, there's emerging data, COVID time data, that video visits are helpful. So doing what you can to encourage patients to be using Skype if they can, or having the nurse help you out with getting like a videos like once a day so that the family can see their loved one or like get a picture or something like that and share with the rest of the family. Getting advanced directives on file will help, especially with the complicated grief portion of family without knowledge of the patient's wishes. So again, encouraging those filing advanced directives for your older patients in clinic, super important. And then finally, post-intensive care syndrome and post-intensive care syndrome of the family. There's actually some good printouts on this online from both critical care guidelines and also UpToDate does have one that's really good at explaining what post-intensive care syndrome is. So I'd highly encourage providing things like that to family members so that they understand what's going on, that they have a name for it. All right. As promised, I summarized everything into one big high-yield slide in order to answer the question, how do we take care of survivors of the hospital? So we're going to go through all these one last time here. So first of all, beware of post-intensive care syndrome. Now you know about it, so name it and then have a high suspicion for it. Remember that it's this interrelated impairment in both thinking, mental health, and the physical function after someone survived critical illness. You might see memory trouble, difficulty concentrating, depression, anxiety, PTSD, other pulmonary issues like dyspnea and exertion, neuromuscular issues and weakness, physical dysfunction, falls, dysphagia, being malnourished, contractures, sexual dysfunction, and sleep disturbance. That is your post-intensive care plus a little bit more. Keep all those things in mind. Evaluate all survivors for PICS and their related issues. So that's a good H&P. That's doing your MOCA, your PHQ, your GAD, checking for PTSD as well. Don't forget to consider your broad differential diagnosis. That's the organic causes, the pre-existing conditions, those sorts of things. Get your blood work and your lab work and your tests, the regular tests. Again, if there would be like a bundle for this, I would recommend CBC, CMP, iron studies, B12, PSH, a chest x-ray, repeat PFTs with diffusion capacity, and a 6-minute walk test. I would just do all of those things on all survivors. And then you'd consider like a CT head study an EMG, but again, those are just for consideration. Regarding treatment and prognosis, my suggestion is like in a one-liner would be to cautiously expect modest but subtotal recovery with multidisciplinary treatment. Again, worthwhile to identify and treat, but you may not achieve someone's baseline. All those individual impairments that you identify, treat them correspondingly and largely intuitively. If you identify depression, treat it like you typically would with depression. Same with anxiety. So all those individual impairments, treat them like you typically, in large cases, like you typically would. Early PT and exercise is huge. Remember, even in the ICU or ICU residents, you can start this when patients are still on mild sedation and on mild pressors. You can do it. So just keep that in mind. OT to help with memory, ADLs and IADLs, feed, swallow, nutrition, home and social support. Manage their symptoms, manage pain carefully. If you're managing any of these things, get specialists involved. That'd be like ENT, pulmonary doctors, just have a low threshold to get specialists involved. Follow very closely at first. Seeing a patient every couple weeks, every month is totally normal, totally regular after critical illness. So definitely do that. And then as they get better and better, you can kind of space out your visit times more and more. Remember that the family is highly involved in this and they are at a high risk of mental health issues, that PICS-F syndrome that we talked about. So inform the family, communicate with the family, involve them, and treat them. Get those advanced directives filed. And then finally, coordinate excellent outpatient care. Be a family physician quarterback or a primary care quarterback. And yes, Aaron Rodgers proud. Go Packers. these are my references, all 50 of them. So I'll go back to this slide. Aha. So, James, thank you for asking the question if ICU survivor support groups exist. I could not find any here in the Madison area. But again, this is kind of an emerging field. There were two relatively well done studies on like peer support groups after survivorship. One of the studies showed that it really helped with the mental health aspects of stuff. The other one didn't. So again, data is mixed. So I don't think it's being super highly adopted. Canada has adopted like PICS clinics a bit more than we have, but we are still exploring that data. Great question. Other questions from people?
Bob, I was just going to say, I definitely experienced this recently, and so did anyone else involved in the care of a younger woman who was in the ICU with COVID. And she definitely had some post-intensive care syndromes or components of it. And it was really challenging to see her struggle after, leaving the hospital at home without her being back to her baseline functional status, dealing with all the emotions associated with that, some symptoms of PTSD, anxiety, depression. And this was the woman who was subsequently admitted with PEs. And there's definitely components of everything you spoke to. And it was really, really challenging for her and required like a multidisciplinary team.
Absolutely. I know exactly which case you're talking about. And I think a lot of us definitely know that patient. Thanks, James. And Jennifer saying that too. John Beasley put a comment in there saying that he suggests that the patient's physical or personal physician be involved in their ICU care. I think that is a really good example. I know for us, we work at St. Mary's, so we're less likely to see our own patients in the ICU at St. Mary's. But when you get that notification that your patient is in the hospital or in the ICU, not being afraid to reach out to family members about that patient, tell them that that you heard things are going on, that you'll be following. I actually gave my COVID patient I was telling you about that inspired this talk. I called him as soon as I saw he got out of the ICU. He didn't answer his phone, but at my first follow-up visit, he mentions to me, he goes, "Hey, thanks for leaving and leaving voicemail when I was so sick. I did get it. I didn't have a chance to call you back, but that really meant a lot." So doing things like that can show that you care and that you're there and that there's more hope as well.
Yeah, if I could elaborate on that, my hypothesis is that if the patient's own physician is there, preferably physically if possible, that would potentially ameliorate a lot of the negative long-term effects. And going back over my career, not most, but some of my most grateful patients have been ones where I was there and showed up. And I didn't do a darn thing medically, but the mere fact of being present with them, I think was important. So I think that we have this segregation of outpatient and inpatient care has had a number of really potentially detrimental effects, and I'd love to see a decent study on it. I don't know of good studies there. Anyway.
Thank you.
Well, this is Jonas. There was a study looking at hospital outcomes when people were followed by their PCP versus the hospital team. And the PCP, if it was the PCP following, they actually demonstrated improved outcomes, not necessarily in the ICU setting. I think it was just hospitalized patients in general, but it makes sense. The other comment I was going to throw out around the prevention practices. So for folks who've been with me at the hospital, we try to emphasize these on rounds like every day. I mentioned it's a little bit tougher to do in the ICU, things like unhooking IVs and taking out a Foley, those sorts of practices, important, but harder to do in an ICU setting, obviously. But as quickly as possible, like part of my routine every day, particularly if someone is confused or at risk of developing delirium, like reorienting them to where they are, but also reorienting them to why they're there. Having family involved as much as possible early on. I know it's really difficult in this crazy COVID time, but Even having family members like stay the night, particularly with folks who are at risk of delirium, like letting people eat what they want, being really clear about activity instructions, making sure they're up in a chair. Even people who are on like a prolonged vent can be up in a chair to eat, but even that little bit of transfer and stuff really makes a difference for people. Encouraging people to get out of bed. So all those tiny little details add up, and there's some really interesting research generally in hospitals, obviously probably even more critical in an ICU setting, but really pushing those prevention practices, I think, is like an important thing we can do every day on rounds.
Absolutely. Thank you, Jonas. Lots of excellent comments in the chat thread as well. Other thoughts? Hearing none, then Tressa will be sending you the summary for you to use. Who knows? Make it a dot phrase, whatever you'd like. I'm making one for myself on this, just because I think I'm going to see it more. If you all have any additional questions or thoughts on this, feel free to reach out to me. I'd be happy to answer those. All right, the time is 8:22. Everyone go enjoy your beautiful fall, rainy, cold Wednesday. Take care.
Thanks, Bob.
Bob.